Namaste guys. So today we're going to study about diabetic ketoacidosis. And yes, I've accumulated from different standard textbooks like Harrison, Davidson, Nelson, and up to date data. But still, I would recommend you to at least study one of the standard textbooks as well, and not only rely on this video. So let's get started. Diabetic ketoacidosis or DKA is a acute life-threatening condition of diabetes mellitus, and usually it is more common in type 1 diabetes mellitus rather than type 2 diabetes mellitus, and it occurs as a consequence of absolute insulin deficiency. So absolute insulin deficiency it has to be type 1 diabetes mellitus. And according to the recent data, around 20 to 40% of children with new onset diabetes mellitus suffer with diabetic ketoacidosis. So what is the diagnostic criteria? Diagnostic criteria ma chai tinta main kura cha, and bicarbonate is secondary. Glucose must be more than 250 milligram per deciliter. Ketone more than 3 or ketone urea 2+ भन्दा बढी हुनु पर्यो. And pH चाहिँ less than 7.3, that is acidosis. So नाममै यसको चाहिँ definition छ. Diabetes भनेपछि glucose it has to be more than 250. Keto means ketone more than 3 or ketone urea 2+, and acidosis means pH less than 7.3 or bicarbonate less than 15. Talking about the precipitating factors for diabetic ketoacidosis, the most common ones are the infection and inadequate insulin, which is usually due to non-compliance. So the infections can be even simple infections or more serious infections. And most important preventable cause is the non-compliance of insulin. Other causes are stress, like physical or emotional stress, any surgery, pregnancy, and drugs. So this is a small mnemonic if you want to remember the precipitating factors. So, the precipitating factors for both DKA and hyperglycemic hyperosmolar state, that is HSS, are same. So we need to remember this is very important. So the symptoms are nausea and vomiting, thirst, polyuria, abdominal pain, and shortness of breath. So this polyuria is complication of diabetes itself, and other causes will be explained, but why this is occurring will be explained in the pathogenesis. So we've already talked about the precipitating events, and now talking about the signs, talking about the vitals first. There is usually tachycardia and tachypnea, there is hypotension and hypothermia. The patient, we said earlier that the most important precipitating factor is infection, but however, even if the patient has infection, the patient may usually be hypothermic. So that is very important to remember. Talking about the pill code, the most important one is the dehydration, and usually the patients are very dehydrated. DKA भन्दा पनि HHS मा चाहिँ नि dehydration को चाहिँ it is very very important to notice and treat as well. Now talking about the systemic findings, respiratory findings चाहिँ नि we have tachypnea, we have Kussmaul's respiration, and we have respiratory distress. CNS complications or clinical signs are the lethargy, obtundation, and possible coma. And talking about the GI features, the patient usually has abdominal tenderness, which may resemble acute pancreatitis. So acute epigastric pain चाहिँ नि हुन सक्छ most patientहरुमा चाहिँ in case of DKA, and we may get confused with pancreatitis. So we have to pancreatitis भनेर सस्पेक्ट गरेको पेशेन्टमा चाहिँ नि ब्लड ग्लुकोज, युरिन किटोनहरु पनि पठाउनु पर्छ. है त नेक्स्ट, नाउ विल स्टडी अबाउट द प्याथोजेनेसिस. यसमा चाहिँ अघि नै भनेको जस्तो साइन्स अनि सिम्पटम्सहरु चाहिँ नि किन आउँछ भनेर पनि अलिअलि चाहिँ यो प्याथोफिजियोलोजीबाट हामी बुझौँ है त. So the pathogenesis of DKA is that there is number one, severe deficiency of insulin, or we can say that absolute there is insulin deficiency. Due to this, our insulin there is decreased utilization of glucose. Hey, number one. And along with that, there is increase in the counter-regulatory hormones, which are the glucagon, epinephrine, and cortisol. अब अघि भने जस्तै स्ट्रेस एन्ड इन्फेक्सन आर द मोस्ट कमन प्रेसिपिटेटिङ फ्याक्टर्स. सो यिनीहरूले गर्दाखेरि चाहिँ नि यो काउन्टर रेगुलेटरी हर्मोन्सहरू पनि बढिरहेको हुन्छ है. एन्ड अलङ विथ द्याट द टिस्युज आर नट गेटिङ इनफ ग्लुकोज बिकज देयर इज द डिक्रिज युटिलाइजेसन अफ ग्लुकोज. सो फर्स्टमा इन्सुलिनकै डेफिसियन्सीले गर्दाखेरि प्लस ड्यू टु द इन्क्रिज इन द काउन्टर रेगुलेटरी हर्मोन्स चाहिँ नि टिस्युज आर नट गेटिङ इनफ ग्लुकोज. यसलाई to counteract with this mechanism, there is now an increase in the glycogenolysis and increase in the gluconeogenesis. अब यसले गर्दाखेरि चाहिँ नि फर्स्टमा त देयर वाज नो युटिलाइजेसन अफ ग्लुकोज, देयर वाज इन्क्रिज इन द काउन्टर रेगुलेटरी हर्मोन्स होइन, प्लस देयर इज नाउ इन्क्रिज ग्लाइकोजेनोलाइसिस एन्ड इन्क्रिज ग्लुकोनियोजेनेसिस विच कजेज सिभियर हाइपरग्लाइसिमिया. अब सिभियर हाइपरग्लाइसिमिया भएपछि ब्लडमा ब्लड ग्लुकोज बढ्ने नै भइहाल्यो अघि भने जस्तै मोर देन 250. Along with that, when there is too much of glucose, our kidneys are not able to reabsorb the glucose, which results in osmotic diuresis and dehydration. So अघिको एकदम इम्पोर्टेन्ट पोइन्ट भने डिहाइड्रेसनको मेकानिजम चाहिँ यही भयो है. नेक्स्ट there is the activation of lipoprotein lipase. यो चाहिँ हाम्रो इन्सुलिन डेफिसियन्सी भएपछि चाहिँ लाइपोप्रोटिन लाइपेज चाहिँ एक्टिभेट हुन्छ. यो द कार्निटिन पाथवे हामीले बेसिकमा पढेको यो कार्निटिन पाथवे एकचोटि रिभाइज गऱ्यो भने चाहिँ हामीले ठ्याक्कै बुझ्छौँ यसको मेकानिजम. सो आई वुड लाइक टु टेल यु टु रिभाइज द्याट. अब वेन देयर इज इन्क्रिज एक्टिभेसन अफ लाइपोप्रोटिन लाइपेज देयर इज इन्क्रिज ब्रेकडाउन अफ फ्याट्स. सो देयर इज इन्क्रिज लाइपोलाइसिस अनि फ्री फ्याटी एसिड्स चाहिँ नि एकदम धेरै बढ्ने भयो होइन. त्यसले गर्दाखेरि चाहिँ नि फ्री फ्याटी एसिड्सहरू बढेपछि एउटा भनेको चाहिँ देयर इज हाइपर ट्राइग्लिसराइडेमिया है. अनि एज वी नो इन प्यान्क्रियाटाइटिसको त्यो नेमोनिक पिएएनसिआरईवालामा टीबाट चाहिँ नि हाइपर ट्राइग्लिसराइडेमिया नै हो. सो अघि भनेको एब्डोमिनल पेन विच मे रिजेबल प्यान्क्रियाटाइटिस भने चाहिँ नि एक्चुअली पेसेन्ट विथ डायबेटिक किटो एसिडोसिस मे अल्सो बी ह्याभिङ प्यान्क्रियाटाइटिस है त ड्यू टु द हाइपर ट्राइग्लिसराइडेमिया. सो क्लिनिकल पोइन्ट अफ भ्यूबाट चाहिँ यो एकदमै इम्पोर्टेन्ट टु रिमेम्बर. नेक्स्ट अब यो like I said, this carnitine phosphate pathway, when there is increased free fatty acid with decreased insulin and increased glucagon, there is the activation of CPT1. यो CPT1 ले चाहिँ लिभरमा गएर चाहिँ फेभर्स द कन्भर्जन अफ फ्री फ्याटी एसिड्स टु किटोन बडिज. मेन यो हाम्रो किटोन बडिजै हो है. किटोन बडिज चाहिँ नि देयर इज वान इज द बिटा हाइड्रोक्सी ब्युटाइरेट एन्ड द अदर इज द एसिटो एसिटिक एसिड. These are very strong acids which release hydrogen, and also acetoacetic acid may be converted to acetone, which is the cause for the sweet fruity smell which is found in most of the patients with DKA. Now due to the strong acids being formed in the liver by the conversion of free fatty acids to ketone bodies and then keto acids respectively, there is release of hydrogen. The hydrogen goes to binds with the bicarbonate, resulting in less bicarbonate in blood, and therefore there is a high anion gap metabolic acidosis. अब यो भन्दा भन्दै चाहिँ अदर कजेस अफ हाई anion gap metabolic acidosis are diabetic ketoacidosis 1, uremia is the other, lactic acidosis and various toxins. So KULT called बाट चाहिँ नि we can remember the various causes of high anion gap metabolic acidosis. Also अब H plus र HCO3 minus भइसकेपछि चाहिँ it causes H2CO3, पछि चाहिँ फेरि यो ब्रेकडाउन भएर H2O र CO2 भयो. अब यो CO2 चाहिँ नि एज यो H प्लस त आएको आइछ, यो HCO3 माइनससँग बाइन्ड गरेर रहेछ बडीमा, देन इट गेट्स कन्भर्टेड टु H2O एन्ड CO2 अनि CO2 चाहिँ एकदम बढ्दै जान्छ है त. नाउ whenever there is an increased retention of carbon dioxide in the body, there is the activation of the respiratory centers which causes the small breathing, resulting again in dehydration as well as respiratory distress. So, due to the pathogenesis को सबै कुराले गर्दाखेरि the consequences are DKA, that is severe hyperglycemia due to अघि भने जस्तै decreased utilization and increased production of glucose. The glucose level may be 250 देखि 600 mg per dl सम्म पनि जान सक्छ है. and it may even be more than 600 in case of HHS. D is dehydration, and this is the most important part. Dehydration चाहिँ किन हुन्छ भन्दाखेरि one is the polyuria due to the osmotic diuresis as well as the ketonuria. Next is due to vomiting, and then tachypnea. Tachypnea चाहिँ त्यही CO2 ले गर्दाखेरि when there is the stimulation of the respiratory centers, it causes faster breathing and tachypnea. And also due to dehydration, there is impaired renal functioning, which may cause azotemia as well. Ani H र D भयो. From K is for ketogenesis due to increased glucagon and decreased insulin. The CPT pathway ma gayo. Then there is increase in the ketone bodies. Ketone bodies causes 1 acidosis. 2 is the activation of the chemoreceptor trigger zone in the brain. So ketone bodies le chai ni brain ma, this is our brain, there is a point called the chemoreceptor trigger zone, and when this is activated by the ketone bodies, which are kind of toxins to the brain, then it results in the vomiting. And sweet smelling breath, the acetone le garदाखेरि there is the sweet fruity smell of the breath. And again, due to the increase in ketone body binding with the H plus and HCO3 minus, resulting in more carbon dioxide, there is activation of the respiratory centers. And finally, from A, there is the acidosis. Due to the ketone bodies which are highly acidic, that is beta hydroxybutyrate and acetoacetic acid, there is increase in H plus. This increase in H plus is then exchanged with potassium, and there may be an increase or decrease in potassium in the blood, which will be discussed later during the investigation part. So अब यो pathogenesis र consequences बाट चाहिँ नि we can know all the symptoms and signs and why it is occurring है त. So we'll quickly revise that. Nausea and vomiting is due to the activation of the chemoreceptor trigger zone due to ketone bodies. Thirst and polyuria. Polyuria is due to both osmotic diuresis due to hyperglycemia as well as ketonuria. Abdominal pain, which may resemble acute pancreatitis. And then we also said that we have to remember, if there is DKA, then there may be acute pancreatitis due to hypertriglyceridemia. Shortness of breath due to the increased activation of the respiratory centers, which causes the increased washout and increased workload of the lungs. So there is tachypnea and Kussmaul breathing. These have all been summarized in the pathogenesis and the consequences. Now we'll proceed with the investigations to confirm whether it is DKA or not. So for the confirmation, the main 3 categories are the glucose, the ketone, and pH. Blood ma what we can do is CBC, RFT, ABG. CBC ma there is invariably leukocytosis. So usually most common it is due to the infection that the DKA is precipitated, and therefore leukocytosis is the most common finding. Talking about the RFT, the urea and creatinine are both raised, and this is due to the dehydration. When there is dehydration, there is no, this causes the increase in the urea and creatinine, and sodium and potassium values may be altered in different cases. Talking about the ABG, it is very important to know the electrolyte status, to know the pH, and so it is, we can say that it is a very important tool for confirming the diagnosis. And another blood test which is very important is the lipase and amylase, which can help to rule out pancreatitis. The other test sample is urine, and in urine we can see for the ketonuria and glycosuria. We can also do the RBS. We have to do the RBS, and we can then, once it is confirmed, then to manage the diabetes, then we have to send other investigations as needed. And if there is a precipitating factor, then we have to send investigations for the precipitating factor as well. Talking about the indicators of severe DKA, one is the blood ketone more than 6 millimole per liter. Next is the bicarbonate, that is less than 5. pH less than 7, and these are the three most important ones, and the others are talking about the vitals. The SpO2 less than 92%, SPP less than 90, and tachycardia or bradycardia, that is more than 100 or less than 60. Hypokalemia less than 3.5, GCS less than 12, and anion gap more than 16. According to the pH, like we said, less than 7 it is severe, 7 to 7.25 moderate, and 7.26 to 7.3 as mild. Now this varies from book to book. So this one is from Davidson, and now this one from Nelson. According to Nelson, if the pH is less than 7.15 it is severe, 7.15 to 7.25 moderate, and more than 7.25 is mild. So these are similar, but here in case of Davidson, pH less than 7 is considered as severe, but in Nelson less than 7.15. So pediatric and adult populations have to be classified accordingly. Now to begin with the management, first we have to confirm the diagnosis, the diagnostic criteria, plus if we can find out any precipitating factors, we have to do that by the diagnostic as well. Then we have to begin treatment as soon as possible in the emergency room, which has to be continued subsequently usually in the ICU or CCU, because these patients usually do require ICU. Talking about the management proper, first is the fluids. Now this management I have compiled from different books like Davidson, Harrison, Nelson. I have combined all the different books into one management. So you can either follow this one, or we'll talk about the management in each book separately as well. And the similarities and differences, we'll talk about that as well. Talking about the management proper, first is the fluids. Fluids, first we have to give a bolus, and then we have to give infusion. And the fluid of choice is 0.9% NaCl, which will be then we will use half NS, that is 0.45% NS. And other fluids which can be used are RL, and mannitol is usually used if we suspect cerebral edema. Now the fluid is given as bolus 10 to 20 ml per kg over the first hour, and then as infusion in the next 23 hours. It is calculated by the following formula, that is 85 ml per kg plus this is the maintenance and this is the bolus. We have to subtract the bolus because it has already been given in the first hour, and then the remaining time in the 23 hours we calculate the required infusion. So this is the management criteria. If the systolic blood pressure is less than 90, then we have to give 500 ml NS over 10 to 15 minutes. And if it is still less than 90, then we may repeat once. However, if the SPP is more than 90, then we give 1 liter over 1 hour, and 1 liter over 2 hours, then 1 liter over 4 hours. So this usually this is simplified into this, and this is the one which is followed in clinical practice. And whatever may be the goal, ultimately it is to maintain the urine output more than 0.5 ml per kg per hour. So fluid चाहिँ नि हामीले 0.5 ml per kg per hour भन्दा बढी urine output हुने गरिदिनु पर्यो. This is the formula which is usually asked in exams, and this is what is usually followed clinically, and this may vary from one place to another. So तपाईहरुकोमा जे फलो हुन्छ त्यो चाहिँ राम्ररी पढ्नु होला. Next, after fluid, the most important part is the insulin and potassium. यो insulin र potassium चाहिँ एउटा गर्दै कुरा गरौँला, तर when we do it clinically, we have to look at both insulin and potassium simultaneously and follow it. Insulin चाहिँ नि we give as 0.1 unit per kg per hour regular insulin, because we have to give IV, and regular insulin is the one which is given IV. Or अहिले चाहिँ नि हामीले 0.15 unit per kg IV bolus दिएर then 0.1 unit per kg per hour चाहिँ नि infusion दिन पनि मिल्छ. As we give the insulin, if blood glucose less than 250 mg per dl हुँदै आयो भने चाहिँ नि NS लाई half NS मा shift गरेर we have to give 5% dextrose. If less than 180 भयो भने चाहिँ नि half NS plus 10% dextrose दिने है. Less than 250 भयो भने 5%, less than 180 भयो भने चाहिँ नि 10% dextrose दिने. And if it goes even below less than 150, then we have to decrease insulin to 0.05 unit per kg per hour. But do not stop insulin. Just decrease it by 0.05 unit per kg per hour. And the main thing for this is to keep the blood glucose between 150 to 250 mg per dl. Because due to insulin, there may be hypoglycemia. And to prevent hypoglycemia, 5% dextrose or 10% dextrose according to the blood glucose. Because if there is hypoglycemia, then we have to stop the insulin. And insulin stop when it is not an option. So in order to not stop insulin, we have to keep giving dextrose as well. Now, whether the blood glucose is falling or not, we have to monitor every hour. This is very, very important. And the goal should be to decrease by 50 to 75 mg per dl every hourly. If there is no response by 2 to 4 hours, if there is fall by less than 50 mg per dl per hour of blood glucose, then we have to increase the insulin infusion. Again, say we were giving 0.1, now it may be doubled or 2 to 3 fold increase गर्ने भन्छ, but सुरुमा चाहिँ 0.1 बाट 0.15 बनाउँदै, and then we may increase if there is no response. Now the common question is till when to continue the IV insulin, and the answer is till the patient has resumed eating and the biochemical status are normal. Once the patient has resumed eating, then we can give subcutaneous long acting as well as short acting insulin. अनि यो हाम्रो जुन इन्फ्युजन वाला इन्सुलिन, यो सुरुको यो इन्फ्युजन वाला इन्सुलिन जुन थियो त्यसको इन्सुलिन, अनि नाउ दिस वान इन्सुलिन, दिस सबक्युटेनियस लङ एक्टिङ र सर्ट एक्टिङ इन्सुलिन चाहिँ नि देयर मस्ट बी अ 2 to 4 hour ओभरल्याप. सो इट्स नट लाइक वी स्टप द इन्फ्युजन अनि त्यसपछि खाना खान थालेपछि एकछिनपछि सबक्युटेस दिने होइन कि, इन्फ्युजन हेज टु बी अल्सो कन्टिन्युड, एन्ड सँगसँगै चाहिँ वी हेभ टु इनिसिएट दि अदर ट्रिटमेन्ट अफ द सबक्युटेनियस एज वेल. अनि 2 to 4 hours पछि चाहिँ वी क्यान स्टप द इन्फ्युजन. नाउ लाइक आई सेड अर्लियर, पोट्यासियम चाहिँ नि हामीले हेर्नै पर्छ. सो दिस इज नट लाइक इन्सुलिन सुरु गरेपछि पोट्यासियम हेर्ने होइन कि, पोट्यासियम र इन्सुलिन चलाउने कुरा चाहिँ सँगसँगै हेर्नुपर्छ है. बिकज इफ द पोट्यासियम इज लेस देन 3.5 or in some books it's mentioned as 3.3 millimole or milli equivalent per liter, then सुरुमै चाहिँ we have to give 40 milli equivalent per hour of potassium. यो चाहिँ हामीले 2/3 as potassium chloride and 1/3 as potassium phosphate दिनु पर्यो है त. And if it's 3.5 to 5.5, then after urine flow is established, that is हामीले बोलस फर्स्टमा 1 liter दिएपछि चाहिँ नि सेकेन्ड लिटरमा चाहिँ नि वी क्यान एड द पोट्यासियम है त. सो द्याट पोट्यासियम चाहिँ 20 to 30 मिली इक्विभ्यालेन्ट पर आवरमा चाहिँ पोट्यासियम जाओस् भनेर. बट इट्स नट गिभन इन द फर्स्ट लिटर अफ फ्लुइड. फर्स्ट लिटर चाहिँ नि एनएस नै बोलस दिने, त्यसपछि इफ निडेड अकर्डिङ टु द पोट्यासियम सेकेन्ड लिटरदेखि चाहिँ नि पोट्यासियम मे निड टु बी एडेड. बट लेस देन 3.5 छ भने चाहिँ नि सुरुमै 40 मिली इक्विभ्यालेन्ट अफ पोट्यासियम चाहिँ दिनु पऱ्यो है त. And if the potassium is more than 5.5, then we don't need to supplement potassium. We can just simply give fluid and insulin. Now talking about the last treatment part, that is bicarbonate. It is very controversial as well, and it is generally not recommended because it is not really associated with good prognosis. So indication चाहिँ कहिले हो त भन्दाखेरि when the pH is less than 7 है त, or when the bicarbonate is single digit भने चाहिँ नि less than 10 भनेपछि 9 less than or equal to 9 भयो भने चाहिँ नि we have to start with the bicarbonate. When we give bicarbonate, if the pH is between 6.9 to 7.0, we give as 50 milli equivalent in 200 ml of sterile water, distilled water. And if it's less than 6.9, then we give 100 in 400 ml. So ठ्याक्क यो 6.9 to 7 भन्दा चाहिँ नि लेस देन 6.9 भएपछि नि यो भ्याल्युहरू चाहिँ डबल हुन्छ है. 50 को सट्टा 100 एन्ड 200 ml को सट्टा 400 मा डाइल्युट गरेर दिनु पर्यो. we also have to monitor, and the things which we have to monitor every hourly are the vitals and the blood glucose, and which you can monitor every 2 to 4 hourly are the electrolytes, the acidic status or pH, and the ketones. And finally, we have to treat the main culprit or the main precipitating factor, whether it is the infection or whatever the main precipitating factor may be, we have to treat that. And this is the resolution criteria. Right? So blood glucose has to be come down to less than 200, the pH has to rise more than 7.3, and bicarbonate has to be more than equals to 18 milliequivalent per liter. Now this flowchart from Davidson has summed up the management very well. We have to first confirm the diagnosis and assess the severity. Severity ko kura hamle agi गरिहाल्यौं. The main things were to look for the pH, the blood glucose, and then we had to also look for the vitals, anion status, and they got their severity mild, moderate to severe garyo. And we have to remember that it is different in the adults and the pediatric population. Then the first we have to start with the fluids. BP is less than 90 or BP is more than 90. If it's less than 90, 500 ml over 10 to 15 minutes ne suruma dine. If it's more than 90, then 1 liter over 60 minutes can be given. Then this is 1 liter over the first 1 hour, then over 2 hours, then 1 liter over 4 hours. त्यसपछि अघि हामीले भने जस्तै ब्लड ग्लुकोजको अनुसार we have to add NS सँग डेक्स्ट्रोज कति % एड गर्ने, अनि NS युज गर्ने कि हाफ NS युज गर्ने चाहिँ नि त्यसपछि डिसाइड गर्दै जाने हो. इन्सुलिन चाहिँ नि 0.1 unit per kg per hour or local protocol है. So local protocol may be first giving 0.15 unit per kg bolus and then starting with infusion 0.1 unit. Then subcutaneous basal insulin can be continued or if it is normally taken, or अघि भने जस्तै कहिले चाहिँ नि स्टार्ट गर्ने भन्ने कुरा भइहाल्यो. Hourly response चाहिँ हामीले blood glucose को चेक गर्नै पर्यो, and according to the goal we have to increase or decrease the infusion pump. And then third is the potassium. Potassium मा अघि भने जस्तै less than 3.5, some books have 3.3. त्यो भयो भने चाहिँ सुरुमै पोटेशियम दिनु पर्यो 40. If it's 3.5 to 5.5, then we can start with the second liter of the fluid, and if it's more than 5.5, then we don't need potassium usually. है अब यही कुरा चाहिँ नि some of the values may be different, but the principle is the same. And this is the most important formula which is usually asked in the pediatric viva as well. So first hour we have to give 10 to 20 ml per kg IV bolus of NaCl or ringer lactate. Then second hour until the DKA resolution चाहिँ नि this is the rate of the infusion है त 85 ml per kg plus maintenance minus bolus by 23 hour, which gives us the hourly infusion rate चाहिँ कति दिने भनेर. अनि like I said, first hour मा चाहिँ 0.9% दिन्छ भने second hour देखि चाहिँ 0.45% NS भनेर यहाँ सुरु गरेको छ है त. अनि यसमै चाहिँ नि 20 milli equivalent plus 20 milli potassium acetate र potassium phosphate छ. We can also use potassium chloride as well. Then usually we use the NS or the ringer lactate, but mannitol at bedside 1 gram per kg IV push for cerebral edema, so is very important. So we have to keep mannitol at our disposal always either. So this is the sample calculation as well. That's why I would recommend you to have a look at this table from Nelson. This is very, very, very important in case of pediatric exam and pediatric viva as well either. And this table from Harrison summarizes everything. So we have to confirm the diagnosis, we have to admit in the hospital, first start treatment in the ER, and then continue in the intensive care unit, that is the ICU. We have to assess the electrolytes, the acid-base status, and the renal function. And then अब त्यही fluids-हरु भयो. First is the fluids, next is the insulin. Patient has to be assessed every hourly के गर्ने, every 2 to 3 hourly के गर्ने. अनि त्यसपछि potassium. पोटेसियमको चाहिँ अघि भने जस्तै लेस देन 3.5 3.5 to 5.5 and more than 5.5 भयो भने के गर्ने भनेर भइहाल्यो है. Then monitoring, as I have already told, hourly what we have to monitor and 2 to 4 hourly what we have to monitor. त्यही गरेपछि सकिहाल्यो. And as I mentioned, it's also written here, administer long-acting insulin as soon as the patient is eating and allow for a 2 to 4 hour overlap in insulin infusion and subcutaneous insulin injection. So that's about diabetic ketoacidosis. We'll quickly summarize it after these complications. The most important complications, this part is due to the management part, and this is just the complications of the diabetic ketoacidosis, right? In case of diabetic ketoacidosis, due to increase in insulin use during the management, it may cause hypoglycemia and hypokalemia, and due to the rapid decrease in plasma osmolarity, it may result in cerebral edema. So DKA like manage गर्दाखेरि आउने complications चाहिँ यो हो, and these are the more common ones. And cerebral edema चाहिँ नि it is very rare, but it is a very fatal complication in case of children. त्यही भएर चाहिँ नि यो rapid decrease in plasma osmolarity चाहिँ हामीले we have to prevent है. अनि solely due to DKA कै complicationहरु चाहिँ ARDS, mucormycosis, MI, thrombosis, DIC and shock. Mucormycosis चाहिँ both due to glucose as well as due to increased acid ले गर्दाखेरि चाहिँ mucormycosis लाई चाहिँ एकदम precipitate गरिदिन्छ है त. Finally, अब HHS को बारेमा चाहिँ नि we have a separate topic, but since we're talking about DKA, just quickly चाहिँ नि difference between HHS and DKA is that blood glucose is more than 600 in HHS, pH is usually more than 7.3. So diabetic ketoacidosis मा acidosis component चाहिँ एकदम critical for diagnosis थियो. यसमा चाहिँ नि pH is more than 7.3 with bicarbonate more than 15. तर osmolarity चाहिँ यसमा एकदम धेरै हुन्छ है, more than 320. So that's why it is called that hyperglycemic hyperosmolar state. Urine ketones are negative or trace because अघि DKA मा चाहिँ नि insulin को absolute deficiency थियो. That's why there was ketone bodies. But यसमा चाहिँ insulin present हुन्छ नि त, and it is present in an amount which is enough to prevent fatty acid oxidation and ketone bodies formation. त्यही भएर चाहिँ urine ketoneहरु negative हुन्छ है त. And difference in management is that fluid deficit is usually greater in case of HHS and dehydration पनि धेरै हुन्छ. त्यही भएर fluid चाहिँ नि एकदम important in case of HHS as well. Fluid of choice is 5% dextrose with half NS. Summarize what we learned. First, we learned the definition of DKA. यसमा हामीले absolute insulin deficiency को कुरा चाहिँ बिर्सनु भएन. Next, we learned the diagnostic criteria. Glucose कति हुनुपर्छ, ketone कति हुनुपर्छ, pH कति हुनुपर्छ, and bicarbonate कति हुन्छ. Then we learned about the clinical features, the signs and symptoms. अनि किन यो signs and symptoms हुन्छ भनेर चाहिँ we learned in the pathogenesis and consequences of DKA. Consequences को चाहिँ नि we have a mnemonic HDKA, that is hyperglycemia, dehydration, ketogenesis and acidosis. अब यसले गर्दाखेरि चाहिँ नि के हुन्छ भनेर we have already learned that. Next, we learned about the precipitating factors, which is basically common in both DKA and HHS. So यसमा चाहिँ नि we have to remember the most common is due to infection, and most common preventable cause is due to the insulin non-compliance. Then we studied the investigations. के investigations गर्न सक्छ to diagnose DKA, to diagnose the complications of DKA, and to know what are the precipitating factors. And we also learned very important about the pancreatitis and DKA correlation. Right. Next, we learned about the management of DKA. यसमा चाहिँ मैले सबै हाम्रो clinically के गर्छ, which is more closer to what's written in Davidson. And in Nelson मा अब PDA को लागि viva point of view as well as clinically एकदम important. अनि Harrison मा चाहिँ नि सबैको summary जस्तो वेमा छ, त्यो सबै डिस्कस भइहाल्यो. And finally, monitoring मा चाहिँ हामीले के गर्नुपर्छ भनेर सबै कुरा गरिहाल्यौं. So again, म्यानेजमेन्ट अफ DKA को एउटा समरी, सबै कुरा यसमै समराइज हुन्छ. कन्फर्म द डायग्नोसिस, एडमिसन, assess the electrolytes, acid base status and the renal function, then start the management proper, which is the fluids, the insulin and the potassium. सँगसँगै चाहिँ assessment के गर्ने त, assessment of what is the precipitating factor, what is the capillary glucose every hourly, and every 2 to 4 hourly what are the vitals and the ketone levels. त्यसपछि number 4 मा we studied about the bicarbonate, अनि त्यसपछि resolution criteria and the management criteria have all been finished. So that's it about DKA guys. Follow for more videos.